essentially a group of vasculitis experts got together and they wanted to create consensus statements that doctors could use to help manage patients with vasculitis. And what they did is a really comprehensive multi-step process where they reviewed all of the existing medical evidence related to a couple of forms of vasculitis. And specifically, they looked at the ANCA-associated vasculitis, so that would be GPA, MPA, and EGPA. And they looked at polyarteritis nodosa, Kawasaki disease, Takayasu's arteritis, and giant cell arteritis. And they went through this process where they reviewed existing medical evidence, they posed questions to each other, and they tried to formulate consensus recommendations about clinical management. So what they were able to do is obtain consensus for many different clinical scenarios. These would encompass things like, which medication should a doctor try first to treat your particular form of vasculitis? Or how should that physician monitor your disease over time? Or how should your condition be diagnosed? And in doing so, they realized areas where the quality of evidence of the literature was quite strong, as well as where it was weak. And this will give, I think, guides to future research endeavors where we can kind of focus on areas where we need to make improvements. Let me show you a little bit of what these recommendations look like so that you can understand how to interpret them when the guidelines do come out. For example, this is a recommendation in patients with GPA and MPA, and the recommendation is as follows, that in patients with active severe GPA or MPA, so most likely these are patients that are newly diagnosed or having a bad relapse of disease, we conditionally recommend using rituximab over cyclophosphamide for remission induction. One of the things I want you to key in on is this phrasing, conditionally recommend. You'll also see recommendations where they say strongly recommend. So a conditional recommendation means that on balance, most doctors in this panel favored starting rituximab over cyclophosphamide. But it's conditional because there may be situations in which cyclophosphamide is preferred. And there may be areas where there's a little bit of wiggle room where a doctor could make a decision and it would be reasonable to try one or the other. So if the quality of evidence wasn't particularly strong, many of these recommendations were conditional. I would point out that these recommendations were targeted for a North American audience. When our international colleagues saw this particular recommendation, it was quite controversial. For example, our colleagues in India were posting on social media that we don't necessarily agree with this recommendation. We prefer cyclophosphamide over rituximab. And similarly, some types of doctors, nephrologists, kidney doctors, for example, may prefer cyclophosphamide over rituximab compared to rheumatologists. So it's important to understand that these were designed mostly by rheumatologists for North American patients, and that there may be differences still in how particular physicians would practice, but they're intended to be guidelines to help the average physician who maybe doesn't have a lot of experience with vasculitis. Another recommendation is the optimal duration of glucocorticoid therapy for patients with giant cell arteritis is not well established, and thus the duration of the therapy should be guided by the patient's values and preferences for remission induction. Sometimes we can't make a clear recommendation because the evidence isn't very good. And you'll see, for example, with prednisone regimens, different doctors do different things. Many doctors hold this belief that putting a patient on a little bit of prednisone and leaving them on a little bit of prednisone for a long time is a good thing to do. Well, that may be their practice, but this recommendation is pointing out that we don't have good enough evidence to point us one way or the other. And so this really needs to be a patient to doctor decision, and that needs to be personalized to each patient. Why are these guidelines important? Well, if you have a physician that isn't quite familiar with vasculitis, and we hear that quite a bit from patients, they're in an area where vasculitis isn't so common, their doctor maybe has seen 1 or 2 patients, these are really helpful guidelines to just give them some structure for how to think like an expert. So I would recommend you print them out on parchment paper, bring them to your physician in a nice little bow, and kindly present them because they're coming out soon. And the other thing I would point out is these are endorsed, will be endorsed by the American College of Rheumatology and co-sponsored by the Vasculitis Foundation. So it really speaks to the fact that the Vasculitis Foundation as an organization has definitely arrived, that they are co-sponsoring important guidelines for the management of these diseases. The next study I wanted to briefly mention is a study called DCVAS, where it's about developing classification criteria for vasculitis. This also is not published, but should hopefully be this year. So what are classification criteria? It's important to really understand this for this study to make sense to you. Essentially, classification criteria are designed to identify similar groups of patients so those patients could be enrolled in a research study. If you were going to do a clinical trial in GPA, you would want patients with classic GPA to go into that trial. You may not want a patient who has very unusual or atypical features of GPA. So the classification criteria allow physicians to study a relatively similar population of patients. The last classification criteria were done in 1990 at a time when microscopic polyangiitis, or MPA, was not even recognized as a disease, and they don't reflect modern practice in terms of they don't incorporate ANCA testing or the latest and greatest imaging modalities. So with these new criteria, we developed them for GPA, MPA, EGPA, Takayasu's arteritis, giant cell arteritis, and hopefully eventually for polyarteritis nodosa. What's very cool about this study is it was extremely collaborative on an international scale. There was participation of 136 sites in 32 countries. We received patient data from over 6,000 patients, making this the largest ever international collaboration in vasculitis. One thing I want you as a patient to understand from this study, however, is these are not diagnostic criteria and they're often inappropriately used that way. So when these classification criteria come out this year, they should not be used by your doctor to determine whether you do or do not have vasculitis. They do not work for that purpose. They're really designed to include similar patients into clinical trials. The next study I wanted to show you is in large vessel vasculitis. There's a lot of advancement in imaging modalities. So we can put patients in imaging scanners and radiology tests and see new aspects of the disease. And one of the study modalities that we like to look at now is called positron emission tomography, or PET scans. And normally PET scans are used to detect cancers, but we are repurposing them to actually look at inflammation in blood vessels. And we can only see inflammation in the large blood vessels. So this would only apply to patients with large vessel vasculitis, Takayasu's arteritis, or giant cell arteritis. If you're a patient with giant cell arteritis, potentially your diagnosis was established by a temporal artery biopsy in which a surgeon removed a small piece of the superficial artery on the side of your head, which is shown in the picture on the left and indicated by the red arrow. This is a pretty safe procedure, but it is invasive. What if we could use imaging tests to actually see and detect the inflammation in that artery and we didn't need to do a biopsy? And that's what this study from a group from Australia showed in ANR last year. And you'll notice these are PET scan pictures on the right, and the little circles are areas of the temporal artery. In the top two, where you see grade 0 and grade 1, this means that the artery was relatively normal. In the bottom two pictures, and particularly in the grade 3 picture on the bottom right, they're showing this yellow haziness over the temporal artery. That is inflammation in the artery. And in the very near future, we may be able to diagnose patients with vasculitis based on imaging tests rather than having to put patients through invasive procedures.